I'm Dr. Henry de la Cruz, and we're going to talk about cough and cold preparations in this session. This is a short session considering that there is no evidence of the efficacy of any of the over the counter cough and cold medicine, and this is supported by an international consortium which has produced the treatment guidelines for the treatment of of common cough and cold syndromes. Most of the drugs that we will discuss will be discussed not so that you can use them, but that you can advise against their use. Several credible guidelines advise against the use of over the counter cough and cold medicines, including the Center for Disease Control, the expert panel on the pharmacologic and non pharmacologic treatment of the common cold. Not only are the cough and cold medications not recommended, but in the case of mucokinetic agents, they are not recommended for acute bronchitis in the cough guideline published in the Chest Journal. A systematic review of cough and cold medications will show that the evidence for safety and efficacy does not meet the main criteria for reliability. Similarly, a Harvard Health publication warns that only minor relief is afforded by most of your cough and cold medications because these conditions are primarily self limited. The American Pediatric Society is more rigid in saying that over the counter cough and cold medication should be avoided in children less than 6 and selectively used in children between 6 to 12. Various agencies have reviewed the efficacy of many cough and cold medications, leading to the banning of phenylpropanolamine as an over the counter medication in the year 2000 due to stroke related illnesses. Carbinoxamine has been uh, removed from the market for its cardiac adverse effects. The MMWR, which is the monthly morbidity and mortality week report, published three infant deaths, leading to the mentioned advisory of withdrawing cough and cold preparations in 2008, and in January and October. The Consumer Health Care Products Association and the Food and Drug Administration provided guidelines for restricting cough and cold use, medication use in children less than 2 and 4 years old. What is a big concern in the Philippines is that many of the advertisements have direct to market targets which focus on the use of these medications on children. There is one medication that particularly even specifies its use for children 2 to 6 years old. It's clear that there is much work to be done for physicians to reverse the effect of mass media, which promotes the use of these over the counter cough and cold medications. Medications for cough can be divided into those that address non productive cough, and this will be the antitussives, and those addressing productive cough, and these are your mucolytics, expectorants, and mucokinetics. Cough suppression should be limited to cough that is ineffective, such as the irritation from tumor or allergic cough, especially when the cough interferes with nutrition or sleep. If you use the antitussive agents for productive cough, it can cause pooling of secretions which can increase the risk for infections. Generally, the central antitussives work by suppressing the cough center in the medulla. This will have the disadvantage of having central suppression at an extreme. There may be respiratory depression. Codeine and opiate derivatives will be one of the most common groups of antitussives. Its active metabolite is morphine, and therefore it shares the mechanism of being an opiate receptor agonist at the mu and kappa receptors, which results in suppression of the medullary cuff center. Its antitussive effect is achieved at a lower concentration than that used for analgesia or sedation, but it may have these effects. So, uh, some people may be sensitive to the effects, to the central nervous system effects of euphoria, somnolence, bradycardia, hypotension, meiosis, ataxia, constipation. Respiratory failure from central nervous system depression may lead to apnea, hypoxia, and coma. Drug dependency can be a problem for codeine, and it is a restricted drug in you require a special license for prescribing codeine. Morphine is a true opioid. Its action as a cough suppressant will be agonism at the mu and kappa opioid receptors, which inhibits your cough reflex. This is one of the strongest antitussives. However, its use is limited because of the overdose potential coming from its ability to also activate delta receptors responsible for analgesic effect. It undergoes significant first pass metabolism, therefore, oral doses are higher than the parenteral required doses. It has short half life of 1 to 2 hours, and its adverse effects have to do with the central nervous system depression. It may cause constipation, drowsiness, and in an extreme, your respiratory depression, somnolence, skeletal muscle flaccidity, cold and clammy skin, meiosis, mydriasis, and symptoms of overdose leading to pulmonary edema, bradycardia, hypotension, cardiac arrest, and death. This is reserved for patients whose cough is not controlled by the usual antitussive agents. A safer option for a non opioid antitussive will be your dextromethorphan. It is centrally acting at the medullary center, but it does not have the usual narcotic properties of the opioids. It can suppress the cough reflex peripherally by numbing stretch receptors and preventing the cough's reflex. Its efficacy is comparable to codeine, and its peak hours are 2.5 to up to 6 hours. Your dextromethorphan can lead to dystonia, bullous mastocytosis, anaphylaxis, and hallucination, ataxia, psychosis. Cerebral degeneration and peripheral neuropathy are rare. Only at high doses do you get effects of coma, dystonia, nystagmus, and increased seizure threshold. Being a centrally acting drug, it may also cause respiratory depression. GI effects include your nausea, vomiting, constipation, and abdominal discomfort. The problem with many of your dextromethorphan advertisements is that it does not uh, emphasize these adverse effects. Butamirate is a relatively fast acting antitussive which acts through central nervous suppression. It has anticholinergic and effects and may inhibit bronchospasm. Adverse effects are nil with generally well tolerated with minimal reports of skin rash, nausea, diarrhea, dizziness, vertigo, which resolves with discontinuation. A last option for cough that is unresponsive to treatment will be the inhibition via your GABA pathways. And this is, however, limited because of the central effects, including your confusion, dizziness, blurred vision, headaches, and memory loss. This makes it more useful for cough that is unresponsive to the usual treatments for chronic cough greater than 8 weeks. Alternatives to avoid the CNS suppression associated with the centrally acting antitussives will be your peripherally acting antitussives. Nebulized local anesthetics such as your pivocaine and lidocaine are used in the preoperative field to reduce the cough or in cough that is resistant to your opiates. The risk for aspiration is present because of the anesthetic effect, so that patients should be asked not to take anything per orum 2 to 4 hours before and after treatment. Pivocaine and lidocaine have been associated with bronchoconstriction, and a pre-treatment with a bronchodilator might be necessary. Systemic absorption of lidocaine is minimal, but if in large or continuous dosage, the risk for inducing arrhythmias is present because of the lidocaine's effect on the sodium entry. Oral benzonatate is effective in opiate resistant cough. It acts peripherally but is reserved for severe cases because some of its adverse effects are central. There may be confusion, delirium, hallucination, chills, burning sensation, and some allergic reactions. Duration of your benzonatate will be up to 6 to 8 hours with a quick onset of action. Mogustin is an oral preparation which inhibits the rapidly adapting irritant receptors in the airway to inhibit the cough reflex. It is considered as effective as codeine in suppressing cough with the advantage of non sedation. It has a rapid onset and relatively long action. Adverse effects are rare, but epigastric pain, diarrhea, rhinitis, and very rarely syncope can occur. Levodoproprisin is the enantiomer of a previously popular cough and cold preparation, your droproprizine. Its mechanism will be on the sensitive C fibers by modulating the neuropeptide levels in the sensory fibers. It is effective in decreasing the transmission of sensation in the airway to suppress cancer related cough in particular, with a rapid onset and rapid remission after 1 day. Nausea, vomiting, heartburn, diarrhea, uh, and some dizziness, headache, palpitations are present, although compared with the parent droproprizine, which is a racemic mixture, it has a lower risk of sedation. The CDC mentions that when a parent and looks for treatments for cough and cold medicine, 50% will have the expectation of an antibiotic prescription. The use of lozenges has the benefit of being less systemic in its effects, but providing some palliative relief. None of the studies on lozenges will claim some efficacy in lowering the duration or severity of an upper respiratory tract infection, but it will be an alternative that provides some symptomatic relief. Studies on the effect of dextromethorphan will not claim to be similar to your oral systemic types of dextromethorphan. In fact, the latest study will show that honey is more effective than this lozenge. For dichlorobenzyl alcohol, it is its mechanism will be to provide some local anesthetic and some mild antiseptic relief, no, from local tonsillar inflammation, but it will not alter the duration or severity of the infection. Benzidamine is also an upcoming NSAID with anesthetic effects, but again, the systematic Cochrane review will show that there is no sufficient evidence to recommend its use for upper respiratory tract infections. Mucokinetic agents will decrease the viscidity of sputum and increase ciliary movement so that phlegm is more easily expelled. Guidelines for the management of obstructive lung disease mention that mucokinetic agents, particularly your N-acetylcysteine, carbocysteine, and erdostin, will be beneficial in reducing exacerbation and improving the general health status of patients with COPD. Carbocysteine, also called your SCMC, will alter the composition of sputum so that it is less viscid by increasing sialomucins and decreasing fucomucins. This is achieved by stimulation of sialyl transferase activity and apparently increasing chloride transport across the epithelium will contribute to decreasing the viscidity of your sputum. Antioxidant and anti-inflammatory properties are also mentioned for SCMC. It is well absorbed with very tolerable side effects, which are rarely reported as headache, nausea, vomiting, gastric discomfort, some bleeding, diarrhea, or rash. We have the capsule and syrup preparation, but not the meter dose inhaler preparation. Erdestin is converted to an active metabolite which splits your glycoprotein bonds in the mucus, resulting in mucolysis. In addition to its ability to be an antioxidant and increase mucociliary transport. It is well absorbed and has a short half life with very minimal types of epigastric pain, taste alterations, angioedema, nausea, vomiting, diarrhea, headaches, dyspnea, and some skin reactions. You've heard your N-acetylcysteine from your toxicology as the antidote for paracetamol poisoning. It contains the sulfhydryl groups that splits mucus glycoproteins, producing less viscid sputum. It also has antioxidant effects, and its metabolites include glutathione, which is the active component in hastening the breakdown of NAPQI, the toxic metabolite of acetaminophen. And acetylcysteine is available as a sachet. The inhaled form is the one recognized as being effective, but it is not available here in our market. Nausea, vomiting, and diarrhea or constipation can limit its use. Angioedema, so allergic reactions with rashes, tachycardia, and respiratory distress are less common. Studies on ambroxol and the related compound, your bromhexine, will show the efficacy in breaking down your mucus to make it easier to expel, but also a special advantage in increasing the synthesis and release of surfactant by type 2 pneumocytes. Ambroxol is well absorbed and depending on the preparation may last 10 to 24 hours if it is your slow release preparation, and it's generally well tolerated with few reports of insomnia, cutaneous rash, vomiting, and abdominal pain. While lozenges are best palliative, your the preparations for ambroxol will include intramuscular and intravenous solutions, granules, tablets, slow release formulations, and a nebulized solution. Expectorants are known to give some symptomatic improvement by increasing the ability to expel phlegm. Guaifenesin is one of the oldest cough and cold preparations. Its active ingredient, iodinated glycerol, acts as an irritant to the gastric mucosa, producing a reflex increase in the airway secretions and increasing ciliary movement to produce a less viscid mucus expulsion. It is well absorbed and excreted as a metabolite. Because of its mechanism on gastric mucosa, it's more common to experience vomiting, diarrhea, and stomach upset with guaifenesin. It is available as syrups, capsules, or granule packets. Antihistamines and decongestants are not only prescribed for cough, but more commonly for the common cold and allergic rhinitis for symptomatic relief. Antihistamines may benefit patients with allergic rhinitis because of its ability to inhibit the histamine 1 receptors, which produce many of your allergic symptoms. In particular, the first generation type of antihistamines produce anticholinergic properties that cause drying of secretions. The problem with first generation antihistamines will be increased sedation. Second generation antihistamines will produce less of the sedation. Third generation levocetirizine, desloratadine, and fexofenadine will have even less of your sedation. The adverse effects, however, limit the use of your antihistamines because drying of the secretions can cause its thickening and make it more difficult to expel. Drowsiness, irritability, and CNS stimulation can happen, leading to tremors, insomnia. In children, there is a syndrome of paradoxical excitability and convulsions. Headaches and stomach upset are also more common among children. Antihistamines should be used judiciously. In the 2017 CHEST guideline, the recommendation was that the second generation antihistamines are ineffective for reducing cough. In the acute respiratory guidelines, which were backed by Cochrane reviews of the studies, it was shown that there is limited benefit of antihistamines in the short term. It does not have any effect on decreasing the duration of symptoms, and the effect of sedation can be troublesome. There is no evidence of its efficacy in children. Generally, there are two types of decongestants which act by producing vasoconstriction. Sympathomimetic amines, such as your pseudoephedrine, amphetamine, benzedrine, mescaline, phenylephrine, and ephedrine, which are the leading decongestants in the market, the action will be to produce release of endogenous norepinephrine, which activates your alpha agonists, causing vasoconstriction. Imida- Imidazolines, such as your xylometazoline, oxymetazoline, nafazoline, and clonidine, cause vasoconstriction through alpha 2 adrenoreceptors, but they may also decrease endogenous norepinephrine through a negative feedback mechanism. The common adverse effects of decongestants will be vasoconstriction that can be generalized, leading to hypertension. This led to the withdrawal of one of the most common decongestants, your phenylpropanolamine due to stroke in the young. In children, decongestants can cause irritability, sleep disturbances, hallucinations, and aggressiveness. Topical decongestants such as your Vaseline, your oxymetazoline should not be used for more than 3 days because it can cause rebound congestion. Prolonged topical use of decongestants like your steroids may be associated with rhinitis medicamentosa. This is a syndrome of rebound congestion and changes in the nasal mucosa caused by chronic use of this medication. The cough guidelines will acknowledge that first generation antihistamines with decongestants may be beneficial for acute cough, especially those due to the upper airway cough syndrome or your postnasal drip, and with throat clearing associated with the common cold. This is one of the few indications for these preparations. Combined preparations of antihistamine with decongestants are available, but when you use the combination, be aware that they will also combine the adverse effects. More commonly, you can experience drowsiness and thickening of the bronchial secretions. Less commonly, you combine the antihistaminic effect of drying of the secretions with nightmares, pounding heart, excitability, and the vasoconstricting effect of your decongestants, which may increase your uh, blurring of vision, confusion, difficulty, or painful urination, unusual sleepiness, weakness, drowsiness, or extreme tiredness. When we talked about your asthma medications, we talked about the short acting muscarinic antagonist, ipratropium. A nasal spray is available which has the effect of drying secretions due to its anticholinergic properties. But like your ipratropium inhaler, the nasal spray may also have adverse effects of headache, nasal or throat irritation, nosebleeds, a bad taste in the mouth, as well as the systemic effects of constipation, tachycardia, blurring of vision, bowel obstruction, angioedema, bronchospasm, and allergy, which are characteristic of your SAMA. This is contraindicated for use in children less than 6 years of age, and generally, the safety and efficacy of nasal spray beyond 3 weeks for seasonal allergic rhinitis is not established. The problem in some of the available preparations of cough and cold medications will be the combinations which do not really make any sense. Dextromethorphan will stop the cough in Colvan, but it is combined with an expectorant. So you stop the cough, but you want to stimulate expectoration. Then you want to give, it's also combined with chlorpheniramine, an antihistamine. So you're expelling the phlegm, but you're drying the phlegm. And there is an addition of paracetamol, even when the patient may not necessarily need the paracetamol. Similarly, dextromethorphan in dinatucin will be combined with guaifenesin. So it's an suppressant with an expectorant and again an antihistamine. So your guaifenesin will cause reflex increase in secretions, but chlorpheniramine will dry it. But you still want to stop the cough too. And sodium citrate is an mucolytic. Eurocough will combine guaifenesin to increase expulsion, but it will dry the secretion with chlorpheniramine, and then it will also give another mucolytic, your sodium citrate. So it's important to be aware of these irrational combinations, and in general, single ingredient will be preferred over multiple ingredients, with the exception of the antihistamine decongestant medications which are used for the allergic rhinitis symptomatic relief. More studies are needed to establish the efficacy and safety of some of your natural products used for cough and colds. Locally, Lagundi has extensive studies on its efficacy not only as an expectorant but as a mild bronchodilator, alagao, oregano, ginger, and calamansi. And calamansi with honey, the honey in itself is a natural product which has multiple effects. No, it's said to be anti-inflammatory and may also have antioxidant effects. More caution should be made for some of the natural products that pose as therapeutic capsules, lozenges, or syrups. Zinc, for example, is generally helpful and can be used as a supplement for patients who are nutritionally compromised. But in the general population, the nasal spray or the lozenges may cause a nausea or bad taste in the mouth, permanent loss of smell, copper deficiencies, anemia, and damage to the nervous system. And yet, it is incorporated even in food supplements. A Cochrane review has recommended that there is insufficient evidence to recommend zinc supplementation for preventive measures. A leading uh, herbal remedy in the US and Europe, leading the sales no, of cough and cold preparations in Germany, for example. Uh, Echinacea is a natural uh, s- um, product which has bioactive ingredients, including your echinacosides, caffeic acid alkylamines, no, and various substances. These will cause fever, nausea, vomiting, unpleasant taste, stomach pain, diarrhea, sore throat, dry mouth, headache. So the things that you're trying to treat may also arise as a result of the medication, in including insomnia, disorientation, joint and muscle aches. In 2019, the results of our Cochrane review again showed that echinacea can be generally safe to consume in the short term. However, evidence is not enough to recommend its routine use for shortening the duration or preventing upper respiratory tract infections. There is much work to be done. We know that next to your leading drugs in the market, respiratory agents, which include your cough and cold preparations, were in the top 10 consumed drug classes in the Philippines, next to your antibacterials. Yet, the respiratory infections, your pneumonia, bronchitis, your even your TB, no, are in the top causes of morbidity. 4 in 5 Filipinos can't afford expensive drugs, and yet much is spent on cough and cold preparations. There is a clear need to educate people, no, the general public, about the true value of these cough and cold preparations. Guidelines on the management of acute cough will emphasize that history and physical exam may provide us clues about the appropriate management of the underlying conditions. In the same guideline, managing the acute causes of cough will in no way recommend cough and cold preparations apart from the recognized use of upper airway cough syndrome remedies. Your antihistamine and decongestant combination may be used. So for the others, your asthma, non-allergic, eosinophilic bronchitis, and GERD, are treated with the specific drugs that are recommended for these conditions, and no recommendation is given to remedy with cough and cold preparations. In the same way, the causes of subacute cough, including again the considerations of pneumonia, asthma, GERD, bronchitis, and airway cough syndrome, only upper airway cough syndrome will be treated with decongestants according to these guidelines. For the treatment of chronic cough, the same pattern of determining the underlying condition and providing specific management, providing the diagnostics to confirm whether there is asthma, non-asthmatic eosinophilic bronchitis, or GERD, will require, none of these conditions will require your cough and cold preparations. Empiric treatment for upper airway cough syndrome will recognize the use of either antihistamines or decongestants. In summary, the World Health Organization will emphasize antihistamines may be effective for allergic rhinitis, but most cough and cold remedies are not recommended. In fact, only water, oral hydration, is the key to most treatments of upper respiratory tract infections and lower respiratory tract infections. For each one of you as future practitioners, we hope that you cannot be part of the problem, part of the type of practitioners who will give prescriptions right and left for cough and cold preparations, which is a disservice to the patient who cannot even afford appropriate antimicrobials or appropriate management, nutrition. We hope that you have more vision and that you can study well for your next exam. Thank you.